So we'll just, let me just start speaking until we get the slides set up. So the topic is a very broad topic. So I've chosen to speak on two primary topical areas of interest. One, to discuss the role of radiotherapy in the setting of a low-grade glioma. And the second, to discuss the role of radiotherapy in the setting of high-grade glioma, and to discuss some recent practice-changing results from major clinical trials conducted internationally, as well as to discuss some emerging areas of interest and active research to perhaps continue to improve outcomes of radiotherapy for these challenging tumors. So as we discussed, we'll speak on these large topics of interest. First, we'll start with I'm going to have to go with you to go next slide here. Okay, so next slide, please. I see. Okay, thank you. So we'll first speak about low-grade glioma. So I'd like to discuss an important result that was published not too long ago, RTOG 9802, that looked at patients who were diagnosed with a low-grade glioma and were defined as high risk based on two features. Number one, having a subtotal resection. Number two, having an age greater than 40. And these patients were treated with either radiotherapy alone to 54 gray or radiotherapy plus chemotherapy, PCV chemotherapy for 6 cycles, radiotherapy also to 54 gray. And this study has been in development and in being followed for almost 2 decades, and very recently has shown very significant results in the sense that it has demonstrated a survival prolongation benefit when adding chemotherapy to radiotherapy. And what this suggests, perhaps, is that aggressive upfront therapy for high-risk, low-grade glioma has the potential to actually impact survival in a manner that we never appreciated previously. This study demonstrated that the addition of PCV chemotherapy to upfront radiotherapy can prolong progression-free survival by at least twofold. They showed that the median progression-free survival in the radiotherapy arm was 4 years, whereas in the chemoradiotherapy arm it was 10.4 years. And that translated into a significant survival advantage, prolongation of overall survival from 7.8 years to 13.3 years. And very recently, the results were further analyzed and presented in abstract form at the Society of Neuro-Oncology meeting last fall, and demonstrated that the survival prolongation effect occurred irrespective of histology, whether a patient had a pure oligodendroglioma, a mixed oligoastrocytoma, or a pure astrocytoma. Although the results with respect to pure astrocytoma were not significant, it was a very small cohort, and we can presume that if it were a larger cohort, the effect would have been the same.